All right, well, it's right at 10 o'clock, so I think we'll go ahead and start. Welcome, everyone. Thank you so much for joining our webinar today. I'm super excited to be able to have such a great group of people here to talk about cancer screening in underserved patient populations. And we'll take a look here, if I can make my slides advance. At our agenda, we have Laura Maycroft from American Cancer Society. She's the Senior Vice President of Prevention and Early Detection. And she's going to be talking to us about screening recovery post-pandemic. And then Vineet Singhal from CareMessage, our co-founder and CEO, will be talking about CareMessage tools for patient activation and cancer screening use cases. So following on Laura's conversation about the need for screening, some tactics for increasing screening. And then Christy has some awesome real life success stories and recommendations from her work as the program manager at the Well Woman Health Check program at North Country Healthcare in Arizona. So really great overview of the need that we see today, some suggestions and tools, and how they're being put into practice. So hopefully we'll all be able to learn something that we can take away and start using quickly here. So without further ado, I will hand it over to Laura, and thanks so much, everyone, for attending. Feel free to put any questions in the question box or in the chat, and we will address them at the end.
Great. Thanks so much, Nora. And Vineet, thanks for having me. Just a quick introduction of where I'm coming from and what I'm going to share today. We can go to the next slide. So I'm a family physician by training, and I've been with ACS about 4.5 years. I have a lot of health center experience, both personally in my clinical life, and then previous to ACS, I worked for HRSA and the Bureau of Primary Healthcare in DC. So I'm happy to join you all today. I know a lot of you are coming from health centers or other health center-like settings. I'm so glad to be with you all today. We're going to talk through a few different things in our short time together. I want to just review quickly breast and colorectal cancer screening recommendations, just to kind of level set and get us all on the same page when we start talking about cancer screening. We'll talk a little bit about the impact of the pandemic on cancer screenings and the implications of delayed cancer screening. And then most importantly, I'll share some tools and tactics to help engage and motivate patients to complete their recommended cancer screening tests. Next slide. So first, screening guidelines. We're going to talk about breast cancer screening guidelines first. So the next slide. So screening guidelines and the breast cancer start at age 40. So we'll go on to the next slide. These are some intro slides. So a couple things to think about. When we talk about cancer screening overall, we really want to make sure we're talking about screening for average risk populations, as well as identifying differences in screening recommendations for high-risk populations. So I'm going to really give a high-level overview of this, but I think it's really important to remember that screening recommendations and screening guidelines really apply to the general population who is not at increased risk, so who is at average risk. And remember, when we think about screening, we're talking about screening for people who don't have any symptoms that might be cancer. So breast cancer in its early stages typically has no symptoms, and we want to find those breast cancers early. So that's really the value that cancer screening brings us, is this early detection and pieces of prevention also. So that's why screening is so important, and why we're so concerned about seeing the impact of the pandemic and how it's delayed people having their recommended cancer screening tests done. So our breast cancer screening guidelines are this. So there's several different organizations or bodies that make cancer screening guidelines. We are one, the American Cancer Society. So is the U.S. Preventive Services Task Force. So we're not going to debate the differences in screening guidelines today. There's a lot of similarities between the ACS screening guidelines as well as the U.S. Preventive Services Task Force guidelines. And then there's a few differences. The important piece is this: the best screening test is the one that gets done. I think the most important thing is that you know what cancer screening is, and that your patients understand what cancer screening is, and that you're following some guidelines and recommendations about what ages to screen and then how screening works. So we're going to talk today about the ACS screening guidelines. This is for women at average risk for breast cancer. So women between the ages of 40 and 44, like I said, breast cancer screening starts at age 40. So between the ages of 40 and 44, women should have the option to start screening with a mammogram every year. So the option means having a shared decision-making conversation with their healthcare team and their provider to understand what breast cancer screening is, what it isn't, what the potential steps are that might come up after getting a mammogram done. Starting at age 45, we recommend that women get a mammogram every year up until the age of 54. Over 55, so 55 and older, may switch to a mammogram every other year or choose to continue yearly mammograms. The distinction here is really about menopause. So in this time, 45 to 54, we're in this time of women's lives where women will start going through menopause, perimenopause, but by 55, we're really in that postmenopausal time. And the science and evidence just tells us that switching to screening every other year past menopause is safe and has the same outcome of every year. Some women are comfortable and want to switch to every other year and feel good about that as their preferences and what works for them. Others prefer to stay and do a mammogram every year. So either way is good, and either way has good science and evidence behind it. We want to continue breast cancer screening as long as a woman is in good health and expected to live at least 10 or more years. Now, the important parts of this, like I was saying, is that I think it's really important that we incorporate shared decision-making into our visits with our patients. Now, that's not easy to do. I understand. There's a lot on the agenda. There's a lot of things that our patients are asking for. They may come in with a totally different acute need than talking about cancer screening, or they may have, a lot of other chronic diseases or other comorbidities that need attention. But just making sure that when we talk about breast cancer screening or any cancer screening, that we really help patients understand what it is. So what does a mammogram tell us? What does it not tell us? And then what might happen if there's an abnormality that needs follow-up? I think sometimes the anxiety that comes up after an abnormal mammogram can be managed if we set expectations early on. The other important part about breast cancer screening for women of average risk is around clinical breast exams and self-breast exams. I get a lot of questions about this from providers and patients. So clinical breast exams are no longer recommended as breast cancer screening. That's not new. That's been around for a long time, at least a decade or more. However, I just think we just all, the way that we're trained as physicians, the way we learn new things, and the way our clinical practice changes, sometimes we need reminders. So the science doesn't support that clinical breast exams make a difference for breast cancer screening for asymptomatic people. If a patient comes in and says they have a lump or something changing, of course you would want to do a clinical breast exam for that, but that's different than just routine screening. The same kind of goes for breast self-exams. So we used to have a really, what do I say, like a big emphasis across the country about wanting to remind women to do monthly self-breast exams. That also just hasn't borne out in the science that it has made a difference. Now, we do really want to help promote breast awareness and help women understand that it's good to pay attention to your body overall. And any changes or new things you're noticing with your breasts should be brought to your provider's attention. So now we'll move on and talk about women at high risk. So certain women are at higher risk for breast cancer, and they should have a breast MRI and a mammogram every year, typically starting at age 30. So this is much earlier. There's a couple of things to think about when we think about women at high risk. So we need to be able to identify those women who do fit this high risk category. And here's the bullet points of who fits into that. So anybody who has a lifetime risk of breast cancer of about 20 to 25% or greater. This is based on a risk assessment tool that are available online. There's a lot of different models out there. They're mostly based on family history. So family history is a really important part of your clinical visits, obviously. It's also, I think, something that we can sometimes overlook just based on the volume, just based on other needs that come up with patients. But it's important that we have some conversation with our patients about their family history, because it can help us identify people who may be higher risk and should start screening earlier. So anybody who has a known BRCA1 or 2 gene mutation, if you have a first-degree relative with a gene mutation and or has not had genetic testing themselves, that also puts them in the high-risk category. People who may have a history of radiation therapy when they were younger, and then people who have genetic syndromes that are listed here fit into this high-risk category and should have a discussion about breast MRI and a mammogram every year, starting younger, age 30. This is all on our ACS website, cancer.org, if you're interested and want to refer back to it. So now let's shift gears and talk about colorectal cancer screening guidelines. So shifting gears, now we're talking about all adults, men and women. We recommend colon cancer screening starting at age 45 for people who are average risk. And they should undergo either a high sensitivity stool-based test or a visual exam, depending on the patient's preference and test availability. So we'll talk more about what those two categories are. So there's a couple different ways to do colon cancer screening. All of these listed tests, both the stool-based tests as well as the structural or visual exams, have good sound evidence and science behind them and are part of our cancer screening guidelines. So beginning at age 45, use any of these following options. So either a FIT test, fecal immunochemical test every year, or a high sensitivity guaiac-based test every year. Now, assuming, and I'm hearing and seeing in my own clinical practice, as well as talking with people across the country, that most places have shifted to FIT test, but the science still supports that a high sensitivity guaiac-based test is okay too if you don't, for some reason, don't have access to a FIT test. Also a multi-target stool DNA test every 3 years. So that's the multi-target stool DNA test is marketed as Cologuard in the US. So that's the one that it's a FIT test combined with also a DNA test. You also have the option of having a structural or visual exam as listed here. So either a colonoscopy every 10 years or a CT colonography every 5 years, or a flexible sigmoidoscopy every 5 years. So all of these tests have good evidence behind them. They're part of the screening recommendations. There's good data and some literature to support that when patients are given a preference of which screening test they should have done for colon cancer screening, that if they have some choice and choose the option that works for them, that they're more likely to complete the test. So patient preference really makes a difference again. And the best screening test here is also the one that gets done. So there's good evidence that says a FIT test every year for average risk individuals has similar outcomes and similar early detection efforts as a colonoscopy every 10 years. So it's important to help patients understand that the one is not lesser, that these are all equal for average risk people. Some people are high risk, so let's talk about that. So we really want to make sure we're recognizing people who are high risk for colon cancer, and we need to recognize who they are and then help them begin screening earlier. We also need to make sure that people who fit the high risk categories, that they only are recommended a colonoscopy. So all the stool-based testing that I just talked about, that's only for people who are average risk and don't have any of these risk factors. So anybody with a personal history of polyps, like for some reason they had a colonoscopy in the past and were found to have adenomatous polyps, they would automatically fit into this higher risk category. Obviously, anybody with a previous history of colon cancer, they would fit into high risk. And people with inflammatory bowel disease also fit the high risk category. Importantly, family history is a key here also. So any family history, especially in a first degree relative of colorectal cancer or high risk adenomas, or anybody with a family history of some kind of hereditary syndrome like familial adenomatous polyposis. That's a mouthful, but that's really important to recognize. If someone starts to tell you a story of all of these different relatives who have had a lot of polyps and a lot of colon cancer, you definitely want to be thinking about hereditary syndromes like familial adenomatous polyposis or Lynch syndrome. For people who fit these high-risk categories, they should begin screening earlier, 10 years before the age of diagnosis of the index case. So that means that if my patient today tells me that their father was diagnosed with colon cancer at age 52, then they need to start their colon cancer screening at age 42, 10 years before that. So that's important to remember, and just make sure you're talking to patients about any family history or other risk factors that would put them on a different screening schedule than average risk. So now let's talk about the impact of the pandemic. So we've just reviewed kind of what we're talking about, and today we're focusing on breast and colorectal cancer screening, but also remember cervical cancer screening has its own guidelines as well as lung cancer screening. So don't forget those also, but just spent a little deeper dive on breast and colorectal since it's a big population of people that are eligible for those tests. So the pandemic has certainly impacted our lives in a lot of ways, and that includes when we think about cancer screening, cancer early detection, and cancer care. So just a reminder kind of what we've all been living through for the past almost 2 years. This is not new, but just a reminder of kind of where we started from, that as the pandemic was declared a national emergency, healthcare systems, including all of you, needed to adjust and help understand like what was going on, what COVID was, what COVID is, how to mitigate the risks of the spread of COVID, and really adjust and tend to the acute needs of patients with COVID. So the ACS, along with other specialty organizations and the CDC, advised, postpone elective care, including cancer screening. We had to do that. We had to put it aside and say, we've got to take care of these acute needs of COVID. However, the pandemic became much longer lived than any of us ever thought it might be. And we knew that the impact of delaying and postponing cancer screening in the long run was we were going to need to adjust and do this different. So we updated information and emphasized the importance of keeping cancer screening still a priority, starting really the first summer of the pandemic. The impact of the pandemic is really felt across the cancer continuum. That's what's just depicted here in this figure. So certainly this reduced access to care that you've all really been working through and living with, the shutdowns and social distancing at the beginning of the pandemic, the fear of infection. People were concerned about going to the healthcare system if they didn't have COVID. The reallocation of healthcare resources. We have a certain workforce, a certain resource allocation, and needing to really use those resources for the acute needs that were happening due to COVID. And then this other important part of unemployment and what that means for access to care, both from a financial perspective as well as insurance perspective. This all led to some delays in routine care. We've seen this in some of the data. Obviously, we're waiting to see the full picture of the impact of the pandemic. We're still really living through it together. But we've seen some early data that really suggests that there was a big impact of the pandemic on screening, which led to some backlog and ongoing needs to keep helping people return to screening. The issue is that if we don't screen people and they don't have access to cancer screening tests or cancer prevention or going in for new symptoms, then we're going to see later stage cancer diagnosis and really, see some impact on all the progress that we've made over the years in decreasing cancer mortality. So this is a big deal and something, it's going to take really all of us working together to help patients get back in for care and to help reduce the risk of cancer moving forward. So this is a quick look. This is not from ACS. This is from the Epic Health Research Network. Some of you may participate in this network. I'm not sure, but this is the best look that I've seen of a best nationwide look at what happens with the pandemic and cancer screening. So this is breast cancer screening, colon cancer screening, and cervical cancer screening among the health systems participating in this Epic research network. So you see sort of the squiggly lines over the years, starting back in 2017, and then you see this big dip, and that's the beginning of the pandemic. That big dip represents about a 90 to 95% decline in cancer screening that they saw amongst these practices in this network. Then you saw some rebounds. That rebound was the summer of 2020. And then you saw a decline again. That was last winter. And then the gap there, this was just through the spring of this year. So that gap from that dotted line, which is the average over the past few years to where things ended in March, still represents about a 30% decline in cancer screenings being done. So that's a lot of people. And I think it just reflects and probably tells us the story that there's gaps that have happened. There's been some rebound and recovery for sure. I suspect as through this year and as vaccinations have increased and we've seen less COVID through the summer before Delta, that the numbers looked better. And then I think we just haven't yet seen the full impact of the Delta variant and what that did for our resource allocation and needing to adjust care and get to those acute needs. And then now I think we're in a new phase as we're facing this new variant also. So one more look at some data on another smaller paper, but important I thought for you all to see is this is a quick paper that we published earlier this year, which was from some community health centers that we worked with. Now, the important thing about community health centers, as you all know, is this really reflects populations who face additional barriers to care overall. And so this was 32 community health centers across the country who got really some small grants, maybe some of you who have got these small grants from us to do quality improvements to increase cancer screening. These 32 were focused on just breast cancer screening. So you see where their screening rates started. This was back in 2018. We usually see that as health centers, as you get just we don't give you very much money, but a little bit of money to do some focused interventions and a little bit of technical assistance to help it just focus on things like screening reminders or focus on fixing something in your EHR that isn't working or have some help to have a navigator, those kinds of things. We see that as we do that we see screening rates increase, and we see that as system changes happen and are sustainable, that those screening rate increases can be sustained. So that's what we were seeing through 2018 then 2019, that screening rates across these health centers were increasing. And then we saw this dip, and this was really just the beginning of the pandemic. The important thing is that we saw the dip, but also I think what we modeled out was that if the trends had continued through 2020, we would have seen a really nice increase in screening rates up to past 60%, which is really would be closer to what the national average is in breast cancer screening. But instead we saw a dip, down below 50% among these health centers. And it just is a depiction and an illustration of what this impact is, and knowing that especially in health center settings and for patients who live in poverty or have low educational attainment, they speak a language other than English, that we really need to continue to have some focused intervention to help them get back to screening or start screening at all in some cases. So now we'll shift, oh, I forgot about this slide. We'll talk about this first. This is just another look at disparities, and we'll move into some tools and tactics about how to help. So this is not news. I think you'll all agree and know that we see disparities in cancer screening across the groups of people who experience greater social and economic obstacles to screening and care based on a lot of factors like racial and ethnic group, sexual orientation, gender identity, education, health insurance status, immigration status, all kinds of things, historically linked to discrimination or exclusion. We are really concerned that this pandemic is exacerbating these social and economic obstacles. And we see that the impact of the pandemic really is disproportionate, both seeing these populations that are facing more COVID, but then also facing the other impacts like loss of employment, loss of insurance, and these are the same populations that are higher risk for cancer. So that's a big deal. The estimates are that 5 million Black and Hispanic people, this was early on, this is an older paper from 2020, but 5 million Black and Hispanic people may have lost their insurance. That may have grown since then. Also, lots of adults are reporting their income impacted and going without or medical care because of that. And then obviously the disproportionate impact on incomes below poverty level. So the disparity issue is big, and it's going to take really a multi-pronged approach to address these obstacles. So we want to make sure that we address those obstacles like this exacerbation of longstanding inequities, that we help overcome patient fear, reluctance, and confusion about cancer screening and cancer prevention. We obviously need to address our primary care capacity, which was not just an issue with the pandemic, but has been an issue in our nation for quite some time. And we need to continue to staff appropriately and help develop good systems of care that strengthens our primary care workforce. This loss of employment and employer-sponsored insurance is big, as I know you all are facing. And then this is a challenge. We're needing to adopt new systems, processes, protocols, using tools like Care Message to help us and then, be able to get to patients where they are and help get them back in for the care that they need. So like I said, it's really going to take us together, and this is what we've been leading this year, is really a comprehensive and multi-sector movement to help mitigate this impact of the pandemic through local and regional action. And part of that is I'm talking with you all today. So I appreciate you all joining us in this effort. We've developed quite a few different resources over this year. This is one of them that I wanted to share with you all that I thought would be helpful to you in your settings, and maybe you've seen it already. If you haven't, here's the download link, and I'm sure these slides will get shared so you can download this at our website there. This was some public opinion research that we did actually last December, so it's about a year old. But it has messages that resonate and that helped encourage people to return for routine cancer screening. And the guidebook really goes through what the messages are for the general population, as well as some different groups of people where different messages resonated better. So we'll talk about a couple of those findings here. So these are kind of big picture findings. There's a lot more in the guide. I encourage you to take a look at it. But importantly, we learned, or maybe re-emphasized, I don't think this was new learning, but we relearned and emphasized that any messaging really has to be culturally competent. We need to understand the needs of our populations of focus, reflect their voices and experience, be sure to translate into preferred languages, and ensure appropriate literacy. And then there's all kinds of information about this in that guide, as well as in our ACS Health Equity Principles linked here. We also relearned through this research that across the board, the most trusted source to deliver cancer screening information is the healthcare provider. So a provider's recommendation continues to be the most important thing that happens to drive somebody to get their screening done. That doesn't mean it all falls on our shoulders as providers. It just means it's an important piece of the puzzle. We want to do everything we can to support that and help patients get a recommendation for cancer screening at every opportunity we have when they interact with us in our clinics. We also learned that more than 50% of individuals in almost every demographic group in our study reported that their care had been impacted by the pandemic. Again, I don't think that's news. I suspect that number might be higher since the pandemic has just lingered. But that just tells us that there's big impacts across the board. The barriers to screening in this study from last year continue to be being asymptomatic. When you're not symptomatic, you're not necessarily thinking about calling your healthcare team and talking. So people don't go in for their well visits. That's something I think we can all continue to work on. People procrastinate. We all have a lot of things on our lists and things to do, and it's just easy to put off things like cancer screening. The cost is a big deal. Reluctance to visit a medical facility hopefully has decreased some over this past year, but maybe there's still pockets of that happening. And then again, 20% of the top barriers to screening in this study was reported as not having a recommendation from a healthcare provider. So things that come through, even like messaging, like Care Message, can make a big difference and help overcome that recommendation, that patients will hear a message about the importance of cancer screening and then know where to go to get their screening tests scheduled. So really, it's true. Together, we are better together, and together with partners like all of you, we really can address this crisis and help reduce the risk of creating maybe another crisis of increased cancer and later stage diagnosis of cancer, and continue to really work to address these disparities and help people get their cancer prevention and early detection services done. Thanks so much. That's my email address there, which will be in the slides. I'm always happy to talk. We also have local ACS staff around the country in your communities. I'm hoping that many of you know your ACS local staff, but if you don't or need a connection, let me know. I'm happy to make a connection and help where we can. Thanks again for having me, and I'll, I think, turn it over to Vineet now.
Great, thanks, Laura.
Thank you so much, Laura. I really appreciate it. It's been great to work with you and ACS for several years now, and it's been really wonderful to have your support and guidance as we have built our cancer screening work. I wanted to, before I get into the specifics of what Care Message is doing, and it fits in really well with what Laura just shared around, some of the guidance and some of the expertise that's coming from ACS and the tools that ACS has developed, and how, Care Message can help implement those. And I actually want to get to Christy's presentation, so I'll try to be as brief as possible, because hers is like an actual real life example, and I'm really excited for her to share her thoughts and North Country's experience. But I wanted to just share really quickly, my own personal connection to this work. I think one of the first memories I have of being in a hospital is when my grandma was undergoing a mastectomy when I was a kid. And that was the first experience that I had. And the first time I was really aware of cancer as a topic. Thankfully, she's doing well. She's still alive to this day and healthy. But, it definitely was something that shaped me and impacted me. And going through that experience as a child was extremely formative for me. And then my co-founder, Cecilia, who wasn't able to join us today, but she lost her father to prostate cancer, right before being inspired to start Care Message with me. So we definitely have a lot of personal connections to this work, as I'm sure everybody here does, and either personally or family or friends or others. And so it's extremely important that we're having this conversation, and especially given some of the things that Laura shared around the impact of COVID and the impact of healthcare disparities that existed before COVID. One of the first applications of Care Message, in fact, was at a free medical clinic in the Tenderloin in San Francisco, where they were using Care Message, or the initial version of Care Message back in 2013, to reach out to homeless women in the Tenderloin district in San Francisco about mammograms, and had huge success there. So we definitely have been focused on this problem for a long time. And I think one of the things that really distinguishes Care Message as an organization, if you go to the next slide, as an organization, is really our focus on the underserved. And unlike a lot of other platforms that are in this patient engagement, patient activation space, that focus on the entire healthcare system, we focus exclusively on safety net providers. We are the nation's largest patient activation platform for safety net organizations. We work with 400 safety net organizations. 1 in 7 community health centers in the US uses Care Message. 1 in 8 free and charitable clinics in the US uses Care Message. We've facilitated close to 300 million messages around lots of things, including cancer prevention and support through our platform. But I think most importantly, we have actual measurable clinical outcomes that we have published, including recent studies that we have done in partnership with the University of Pennsylvania focused on colorectal cancer screenings. And that's really important because we really hold ourselves to a very high standard in terms of outcomes. And the way that that is manifested, if we go to the next slide, is really through our tools that are focused on driving very tailored communication that is designed for the needs of the underserved population. So all of our messaging is at a 6th grade reading level or below. 80% is at a 4th grade reading level or below. We have a strong focus on Spanish speaking patients and take into account things like the variations in different words between Mexican Spanish and Puerto Rican Spanish and other Spanish dialects. We're also focusing on expanding to other languages over the course of 2022 in more meaningful ways. And I think the other powerful thing about Care Message is really the data. That's because we have facilitated hundreds of millions of messages exclusively with underserved populations. We have a lot of insights into the kinds of things that impact this population, the kinds of things that drive the most engagement, variables like tone, frequency, timing, those types of, what day of the week, what time of the day is best to send a particular message, what types of responses or what types of questions get the highest responses, those insights and best practices that we have collected and perfected over many, many years. And then in addition to that expertise, we also have our technology platforms. If you go to the next slide, we have patented tools that are that power sequential messaging for underserved populations. And not all of these are relevant to the topic of the day, but just to give awareness to obviously a lot of the functionalities that enable organizations to adopt Care Message as a one size or centralized tool, I should say, for patient activation, including on this important topic of cancer screenings and prevention. And again, the underlying thesis is that we want information and we want engagement and activation to be tailored, and we want it to be personalized, and we want it to be helpful, particularly for populations that have very unique needs, but we also want it to be automated because we know that automation is key, particularly in safety net settings that don't have a ton of resources, that there's not a lot of time, and it's really important to be able to automate things, particularly with the impact that COVID has had on healthcare workforce more broadly. So if you go to the next slide, I'll share a little bit about some of the tools that we have available that help us automate some of those things for cancer prevention and awareness. And screenings obviously are a big topic and a big point of emphasis. We have a lot of organizations that send messages to patients around cancer screenings that are both one-way messages and two-way messages, and those have been extremely successful. We've also obviously, as I mentioned before, have a lot of best practices that inform exactly how messages should be constructed and what is the right frequency and timing and tone for those messages, and particularly for messages that require response from the patient versus those that are one-way messages. And then we also have done a lot of work in terms of automating not just the experience for the patient, but also the integration with tools that are being utilized by our partners. So one example, for example, is our integration with Azara. So for organizations that are using the Azara interface or the Azara population health tool, we have a built-in integration with Azara that allows full automation through a mechanism we call set it and forget it, where we could have these ongoing rolling outreaches or communications going out to patients, and there's automation built in. So the communication only goes out when a patient is actually overdue for a particular screening, and it can be tailored to the needs of the individual organization. And then beyond just one-way messages or bidirectional messages, we also have sequential messaging. If we go to the next slide, and this is often very helpful because sometimes you need to follow up with patients. A single message or a single interaction is not sufficient. And so we actually have received 2 patents now for some of the underlying technology that enables this. But ultimately what this is being able to automate follow-ups with patients that can be very helpful in reminding them, especially if they're not responsive the first time, to follow up a second time or a third time about getting screened and providing education, sending videos and other links to help them set appointments and ensure that they have returned their fit kits. And I'll just point to the quote at the bottom of the slide there, which was a study that we conducted in partnership with the University of Pennsylvania at an FQHC in Philadelphia that showed that by having sequential serial messaging versus just a single message, they were able to see a 17% completion rate for colorectal cancer screening versus, I believe it was 2% for a single message. So having sequential messaging is helpful and can actually have an increased impact on cancer screening rates over time. If you go to the next slide, we've definitely also seen not just improvements in cancer screenings, but also referrals. We know that a lot of times health centers will refer patients to screenings in other settings, particularly, and not just referrals for screenings, but other types of services tied to cancer prevention and management. And so we have a feature that is focused on automating the process of following up with patients after a clinical referral has been initiated, and closing the loop, actually following up, making sure the patient understands what the referral is about, where they need to go, that they have booked an appointment, and also that they have attended that appointment, and automating that entire process of communication with the patient. And again, sharing that quote from a health center in Northern California that showed that our feature dramatically improved their ability to close the loop on open referrals in an automated fashion. And then I'll just share a couple of other data points, but I really, again, want to get to Christy's presentation because she goes into a lot more depth. But again, tons of really good examples of organizations that have seen improvements in getting new appointments scheduled, as well as new screenings scheduled, and that translating into improvements in their screening rates overall and their scores as organizations. And then finally, I wanted to talk about how organizations, particularly those that are not already using Care Message, can take advantage of this. And this is something that we launched. I think we've talked about this for a while, but a CM Lite, again, a free version of Care Message that was really created for COVID. We've made it available to now almost 200 organizations. Almost, between 3 and 4 million patients have we reached through just CM Lite, which is a COVID-specific version of Care Message that we made available now since March of 2020. But only recently we decided to make CM Lite a permanent offering. So it's something that organizations can really use as a trial for Care Message. It takes 1 day to implement CM Lite. It's 90 days of use. There's no obligation thereafter. If organizations want to use it for 90 days and then not use it again, that's not a problem. But it often is a valuable way for organizations to try out in a non-integrated way some of the basic functionality within Care Message that often enables some of the use cases that we have talked about around cancer screenings and prevention. But I think really what is exciting, in addition to talking about CM Lite, is how Care Message is being used in the field. So I'm just really excited to share and invite Christy from North Country Healthcare. Christy and I were talking before the presentation. We couldn't decide if we've been working with North Country for 3 years or 4 years. But we definitely have been working with them for a long time, and I'm definitely excited to share for her to share more about the work that they're doing and the great success they've seen with Care Message around cancer screenings. So, Christy, thank you.
Thank you, and hello, everyone. Just to give a little bit of history, I've been with the Well Women Health Check program, the program manager for almost 5 years at North Country. And I'm excited to be here today and share a little bit about our program. I am super passionate about what I do every day for our program and our patients. as I am a 2010 breast cancer survivor. So January 2022 will be 12 years since my diagnosis. Next slide. Although Well Woman Health Check Program has screening sites located throughout Arizona, the North Country Healthcare Well Woman Health Check Program provides breast and cervical cancer screening and diagnostic services across northern Arizona. We cover 5 mostly rural counties. It's approximately 58,000 square miles across northern Arizona that we strive to increase women's access to cancer screening services. We are always looking for new ideas to improve women's access to healthcare. COVID-19 completely threw us for a loop, and we've been trying new outreach attempts for better outcomes to achieve our program goals. Next slide. We have 3 programs offering services within our Well Woman Health Check program. The first one is a clinical services program for the underinsured and uninsured patients. Underinsured is defined as having insurance that does not cover screening or diagnostic services. And this also includes patients that may have a high deductible or copay that prevents them from obtaining cancer screening services. Our Well Woman program pays for all the services provided to the patient under this program. A second program is the navigation only program, and it's specific to insured patients. And this program provides navigation services to the patient that includes appointment scheduling, education, assistance to reduce barriers to obtaining those cancer screenings, and the insurance covers the cost of those services provided through our program. And finally, we have a treatment link program for the clinical services patients that enroll with the Well Woman Health Check program that are diagnosed with breast or cervical cancer that are not able to obtain other cancer treatment services. This program pays for a patient's cancer treatment solely through grants and donations. On average, we assist about 5 to 15 patients a year at different varying stages of treatment. And we accomplish that on a budget of about $150,000 a year. Next slide. This is an overview of our breast and cancer screening demographics in northern Arizona. We have a high Hispanic population of patients for breast cancer screening and services in northern Arizona, approximately 43%. We do offer bilingual program staff members to better assist with the Hispanic patient population and also send text messages in Spanish as well regarding breast services. In 2020, 7 of the 11 patients diagnosed with breast cancer were diagnosed within a 2-month time span of us being able to offer cancer screenings again in June due to COVID-19. We halted screenings for 2 months beginning in April 2020. And so in that 2-month time span, we lost out on a lot of screenings. And once we were able to reach our patients again through text messaging and letting them know we were still screening, please join us, make an appointment, we had a significant amount of cancer diagnoses that happened during that time span. Next slide. This slide reflects our COVID-19 impacts for breast cancer screenings. The March 11th timeframe is noted with a significant drop in breast cancer screenings due to the COVID-19. And April 2020, our North Country Healthcare Chief Medical Officer halted our program cancer screenings. We were able to resume those screenings in June 2020, and we have continued to increase our cancer screening rates through 2020. And I'm actually excited to see our completed 2021 annual report, as I know the recovery trend has continued to improve, although it's been difficult at times over the last year. As you can see in a couple more slides, the breast cancer screening services has improved faster than the cervical cancer screening services, but I'm sure we've continued that trend in improving those. Next slide. This slide is a comparison of the breast cancer screening services completed it was between 2019 and 2020 for COVID-19 impacts. And there were significant reduction of those services that were provided in that time frame. You can see as drops of several hundred in certain areas, from a clinical breast exam to a mammogram to an ultrasound. So we definitely felt the impacts of that in our program. Next slide. This is an overview of the cervical cancer screening demographics in northern Arizona. And as with the breast cancer screening demographics, the cervical cancer screening demographics also has a very high Hispanic population of patients in Northern Arizona. We are definitely higher in the cervical side at 61% versus the 43% in the breast side. And we still offer the bilingual staff members and then the Spanish text messaging regarding our cervical services as well. In 2020, we did see a decrease in patients with a cervical cancer diagnosis, 9 in 2019 and 5 in 2020, which we believe is due to COVID-19 and a decrease in the cervical cancer screenings and office visits. There's definitely a fear of coming in for those services, and I think that impact is well noted based on our percentages. Next slide. As with the breast cancer screening services, the cervical cancer screening services were impacted due to COVID-19 as well. Cervical cancer screenings were also halted in April 2020 and resumed in June 2020. The cervical services have been a little slower to recover than the breast cancer screening services, largely impacted by the availability of clinic appointments and fears of coming into the clinics for those screening services. We've had to be more creative in our communication with patients to inform them that the screenings are still happening and to please schedule their appointments and join us. Next slide. This slide is a comparison of the cervical cancer screening services between 2019 and 2020 with COVID-19 impacts. As with the breast cancer screening services, there was a significant reduction in those cervical services provided in 2020. And we're looking forward to potentially getting those back on track again and bringing those up. We definitely want to increase our services again for our patients. Next slide. So our challenge is to increase our breast and cervical cancer screening rates again and getting them back to our pre-COVID-19 days. COVID-19 brought about many changes, including our patient referral processes for screening services. Adding in text messaging has been extremely beneficial with contacting our patients in need of services or healthcare gaps. We've been able to share that we are still providing cancer screenings during the pandemic when we have a mammogram mobile unit scheduled in a local community and that a patient is due or overdue for services and to call us to schedule their appointment. Our text messaging has increased over the last 18 months and is assisting us with patient communication in so many ways. Next slide. We increased our mobile mammogram units across 5 counties in Northern Arizona in 2020 and continued that trend into 2021. We also increased our social media advertising and text messaging efforts. Not only have we been advertising our scheduled screenings, but we also started a new text messaging effort on March 31st in 2021 to automate patient reminders for routine screenings and appointments. We worked with Care Message to create a set it and forget it patient reminder automation project where we developed workflows to allow patients to engage with us through text messaging. We created phone trees for program staff to answer the calls and offered online link within the text messages to connect the patient with a screening request form for scheduling an appointment, trying to reach them in every avenue that we could to simplify that process to get them scheduled as quickly as possible. This text messaging automation project included a 3-part text message series to the patient regarding their breast and cervical cancer screening services that were due. And I'm happy to report that from March 31st to September 30th, we assisted patients with closing 491 healthcare gaps through the text messaging process. On average, it did take patients about 8 weeks to fill their gaps, but that was expected just with trying to arrange appointments and getting them in, but just ever so excited to close 491 gaps was just significant to us and so beneficial. The set it and forget it patient reminder automation program was a success for us. So we were really excited and we were able to add that in with our original text messaging and our mobile mammogram units within those local communities as well to advertise that we were there. So not only did the patient receive a reminder that they were due for their services, but then we also were bringing this mobile mammogram bus into their area so that they could conveniently schedule their appointments. Next slide. The See, Test, and Treat program event was held on Saturday, September 18th in 2021. The See, Test, and Treat program is a grant opportunity through the College of American Pathologists Foundation. And this program is a single-day event that provides same-day or prompt patient results, a connection to follow-up care, education, and a goal for removing obstacles that keep women from following through with preventative care. This one-day approach effectively addressed barriers encountered by uninsured women that have little or no access to preventative care. North Country opened for Saturday office visits and for breast and cervical screenings. Providers and clinic staff participated in the event. We also had 4 mobile mammogram units available on site for appointments. We offered food, healthcare navigation services, along with community vendors and attendance. We reached out to our patient population through bilingual text messaging and completed just to promote the Saturday event and to encourage both screening services across 2 counties. And as you can see, we had increased numbers from 2020 to 2021. We did have more follow-ups to address in 2021, but that was to be expected as, you know, some of those numbers doubled and tripled by the outreach through text messaging for our program of services. Next slide. So to kind of give a little bit of information leading into 2022, we have increased our calendar event schedule to 70 mammogram screening events throughout Northern Arizona. We've connected a provider to add cervical appointments to our mammogram screening events for 2022. And this added appointment availability and increasing services to women. 2 cancer screenings completed in 1 visit. I feel like that's a win for our patient population. And we're also increasing our text messaging to connect more of our cervical services to our mammogram events. And that's kind of tied into adding those providers to those events. So we will be sending out additional text messaging and then adding program flyers to connect our cervical services as well for our patients. We are always looking for new referrals and partnerships, and we have partnered with several healthcare insurance companies, reaching out to their members when a mammogram mobile unit is in their local area for members to receive their services. So when that text message goes out, we're able to offer those services to insured, uninsured patients, and then the health insurance partners are also text messaging their patients to offer those services as well, which does include Arizona Complete Health, Care First, Health Choice, and Blue Cross Blue Shield. So just those added partnerships have made a significant difference for bringing those patients in. And as always, we will continue to evaluate and drive the momentum to increase our breast and cervical cancer screening rates. We will continue to show up, and we're not going to let up. We want to increase these. So I appreciate you joining us today and thanking you for your attendance.
Thanks, Christy. That's awesome. Awesome experience. And I think I'm having a hard time advancing my screen, but there we go. I just wanted to see if there are any additional questions. We had one question from Jose asking if the slides will be available. And thank you, Thad, for responding that we will share the presentation and recording after the webinar. I know I had some emails from people who were not going to be able to attend, but wanted to be able to be sure to access the recording. So if there's anyone who you think could benefit from viewing the recording, definitely share this with your colleagues, and don't hesitate to reach out to us if you have any questions. But I think we've got about 5 more minutes. So feel free if there are any additional questions in the chat, or I don't know, presenters, if you have anything else that you wanted to make sure to mention prior to wrapping up. Again, Vineet mentioned the Care Message CM Lite offering that is a scaled down version of our Care Message full platform that's available for free for 90 days to try our outreach functionality for use in COVID-19 use cases, but also in outreaches to encourage cancer screenings. I think Laura and Christy shared some really compelling information about how much that's needed. So definitely feel free to reach out to us if that is something that you're interested in learning more about. Anne did ask a question that we just received, which is, do you have any resources on how to make breast cancer screening more trans inclusive? Which is a great question. I don't know, Laura, if that is something that you've explored in your Return to Screening initiative or have any best practices around.
Yeah, it's a really good question. The guidebook that I talked through did not specifically look at transgender people. There, LGBTQ kind of overall is in there, but not specifically with transgender populations. But it's a really important point and super important to make sure that the right screening recommendations are offered to our transgender patients also. So I don't have a lot to say specifically on that, but I think it's a really important question. I thank you for the question. It is something that we at ACS are, kind of actively working with partners on. There's the LGBT, I think it's called the LGBT Cancer Network, or might be LGBTQ. I'm not sure. I apologize, but they're a great partner to us and are more specifically expert in those populations. So I guess my only offering on that is that it's an important piece to remember, to make sure that we recognize our transgender patients and offer them the right cancer screenings for the anatomy that they have.
Great. Thanks, Laura. Any other notes, Christy or Vineet, on that?
The Well Woman Health Check program does offer services to the transgender community as well. So it is a provided service for us under our program guidelines. So, our doors are always open and accepting those screenings.
Great.
I think the only thing I'd add is, it's one of the more important areas of exploration. Obviously aligns with our languages work, but a lot of other things is making our technology and tools as accessible as possible. So we spend a lot of time thinking about, pronouns and how do we categorize gender and some of those types of things within the application. So that's maybe more of a technical answer. I think we have more work to do in terms of making our messaging more trans accessible. So I think we're learning more than anything, I would say at this point, but definitely something that aligns with our broader goals around accessibility.
For sure. Thank you, Anne. That's a great question and definitely something we should all have at the forefront of our minds. Okay, if there are no more questions, I think we can wrap up. It's almost 11 o'clock. So thank you again, Laura and Christy and Vineet. This was an awesome conversation, and let's take this knowledge and put it into practice. Thanks so much, everyone.